Hello and welcome to this monitoring fluid therapy presentation. I've specifically done this presentation to accompany a fluid therapy video I did recently on calculating fluid rates. In that video, I talked about calculating not only fluid maintenance rates, but also fluid deficits and ongoing losses, and essentially making fluid plans and rehydration plans for our patients. And we can't talk about fluid therapy and calculating fluid therapy rates without really talking about monitoring fluid therapy because it is so important for our patients that we monitor the fluid that they're given. So let's look at what we know about fluids. IV fluids are frequently prescribed. And yes, I say prescribed because vets do prescribe fluids. They prescribe fluid prescriptions. And as nurses, we often prepare those fluids and get the patients on fluids and even place the IV catheters. And it's our job also to monitor the patients and report to the vet if we're concerned. But it's a fundamental part of hospitalization in the majority of patients. We can definitely say that a lot of patients are put on IV fluids. And the other thing we know is that it's super important to have enough fluid in the body. The body needs enough intracellular and extracellular fluid for perfusion. But we also know, or we should know, that excessive volumes of fluid can cause serious complications. And we don't just want to go giving fluid to patients that don't need it. There's only so much space within the body. And if we give too much fluid to fill that space, we can start to see problems. These problems can include pulmonary edema. So this is where there is so much fluid within the body, within the vessels of the body, that the fluid is being actually pushed out of the vessels and into the tissues, specifically the tissues of the lungs. And we can hear pulmonary edema in the form of crackles when we listen to our patient's chest. I often think it sounds like bubble wrap popping. We can also see excessive amount of fluid in abdominal cavities, such as the thorax and the abdomen. And we see pools of fluid like this, we refer to it as ascites. And we can even see edema in peripheral limbs. So we see peripheral edema. And this is just simply, again, fluid that's being pushed out of the vessels and when there is just too much or the pressure is too high, and it accumulates in the cells of the limb and the tissues there, and we get really puffy extremities. And we'll all be familiar with the term fluid overload. Fluid overload is not good. It can be really detrimental to our patients for a variety of reasons, but it is insane what fluid overload can actually affect to our patients' immunity, to clotting factors, to nutrition. I have a slight problem with the term fluid overload in itself. Fluid overload to me sounds like we or I or you have overloaded this patient. That to me sounds blameful. And I think a lot of people would agree when we hear the word fluid overload, we don't want to be the ones that fluid overloaded. We want to be like, oh, person X overloaded this patient. And even that, it just sounds blameful. And there's a real negative connotation around the word fluid overload. And yes, if you are the nurse that has not detected the fluid, that there has been overload, or the other vet that has prescribed the fluids in the first place and the patient's become overloaded, we can feel really negative emotions, guilt, shame, regret, sadness. And I actually think we're doing a detriment to ourselves. And I'm going to go into why I think the fluid overload isn't just because of the fault of the clinical team. Sometimes there is no reason why we shouldn't be giving these patients fluids. We have no indication that the patient cannot cope with the fluids we're going to give. So we have no idea this patient's going to become fluid overloaded. And that is the point, really. The only way we're ever going to know is through monitoring. On the outside, with physical exam, it may have looked like a healthy patient and we're putting on maintenance rates. So why would we think that we were going to fluid overload these patients? But put simply, it's because some animals are just less tolerant to fluids than others. It is well known that patients with heart conditions don't deal with fluid very well. But if these patients have no heart murmur, no arrhythmia, no reason for us to suspect that there is a cardiac problem going on, and that's just one example, then there's no reason to suspect that this patient cannot cope with the fluid we're going to give it. So rather than focusing on excessive fluid load as being called fluid overload, which, as I said, has negative connotation, it assigns blame, I believe, to clinicians, I instead like to flip it and think of fluid tolerance. It removes the blame from the clinician. Don't get me wrong, sometimes we don't get it right. We do give too much fluid, we miss the signs. But what I mean is sometimes for our best efforts, it still happens. And in these cases, it's whether or not we should be asking ourselves whether or not the patient can tolerate the fluids that we're going to give them. And it's really good if we can ask this early on before we start the fluid. We make a judgment based on, yes, we think they can tolerate these fluids, but then we monitor the patient. And at the first point of intolerance, the first signs the patient has shown us that they're not tolerating these fluids, it's about picking up on it and reporting it and then doing something about it. So as I said, the tolerance for fluid varies from patient to patient, and there is simply no way of us accurately measuring tolerance. That's not something that we can do. We can't do that before therapy begins. We can only make a judgment based on the physical exam that the vet is carrying out on that patient. But some reasons for some fluid intolerances that we may see are small body size. So smaller animals just have less space for less fluid and there's more room to get it wrong. Larger volumes of fluids, diseases, and inaccurate estimates of fluid deficits. I think it's really important that when we're making rehydration plans, if the vet thinks the patient is 7% dehydrated, that is an estimate. We have no way of properly knowing that. We're going off physical examinations, heart rate, capillary refill time, skin tenting, how sunken the eyes are. So it's all just estimates. There's no way of us knowing that these patients are actually exactly 6% dehydrated. They may instead only be 4% dehydrated, and that means we're going to give an extra 2% of fluid which that patient does not need and therefore may not be able to tolerate. And what you've got to remember, it's not just the fluid that we're putting into their vessels, it's actually we've got to add this to the fluid that they're drinking. So if you've got a thirsty patient, they're going to be taking in more fluid orally. We've got to look at the fluid that we're flushing medications in with. Maybe this patient's getting quite a bit of flush every day. Maybe they're being tube fed or syringe fed and they're actually getting quite a bit of fluid following their feeds. It all adds up. Now, as I said before, it's quite commonly known that heart disease can result in our patients not coping well with fluids. That's kind of one people go, fluids aren't good, then it's heart disease. And it's essentially because heart disease results in inadequate ejection of blood out of the heart. And that's simply because the heart does not work properly. So if the heart's not pumping properly, then it's not very good at pumping an adequate amount of blood out of it every beat. And that can be for different reasons depending on the disease. Some examples are dilated cardiomyopathy is a condition quite common in larger breeds, and it's where the heart simply doesn't contract properly. So without that contraction, you're not going to get that nice ejection out of the heart when it beats. Hypertrophic cardiomyopathy, or HCM in cats, this is the opposite. It's the heart does actually relax fully. And if the heart doesn't relax, it doesn't fill. And therefore, when the heart pumps, it doesn't have a nice amount of blood that comes out of it, or that ejection of the blood is again reduced. So what we do know about cardiac patients is they can't cope with much fluid, and sometimes they can't even cope with their own blood volume. Their own blood volume even holds them back. So their heart is trying to pump their blood around their body, but it struggles, and fluid gets built up and it can collect in places like the lungs, which is that pulmonary edema that causes the crackles. So this is why we've got to look at even maintenance rates as not being safe. Maintenance rates still require monitoring. And it's really important to remember that maintenance rates should be based on lean body weight. We shouldn't be working out fluid therapy plans for patients with excessive body weight. We need to be going off lean body weight as well, because again, that can result in too much fluid being administered. And let's just take a moment to talk about occult heart disease. This is underlying heart disease that is not detectable on physical exam, i.e. there's no murmur and there's no arrhythmia, just like what we were talking about earlier. The only way you could possibly pick this up is doing an echo on the heart before the patient starts fluids. Now, that just simply isn't going to happen. It's just not practical. The easier thing to do is just to monitor and report signs that our patient isn't coping with the fluids and report them early. What are the signs of intolerance? Firstly, we want to be checking things like respiratory rate and effort. Again, I'm quite pedantic myself, monitoring these in cats and small dogs as well, because again, their tolerance scores can be lower. They just have less volume, less space. I like to do that every 2 to 4 hours. I like it when my vets also chart that on SmartFlow. And for me, it's a good prompt. We also wanted to be monitoring body weight once to twice daily. Again, for little babies, we want to be doing it quite often, even every 6 hours if we've got some neonatals in or some pediatrics. And cats, it's good to do twice daily if you're concerned, but as an absolute minimum, once every 24 hours. And we should also be looking at urine output. Are we dealing with a patient that's day 3 of hospitalisation, it's had its procedures done, it's just having some supportive care, and we've noticed a vast increase in its urine production? This cat is going its litter tray all the time. Like, I'm having to constantly clean this cat's litter tray, and it's getting quite annoying. That should flag something in my mind to at least tell my vet this cat's urine has increased or urination has increased. It seems to be having quite a lot of urinary output. That may be one of the first signs. And it's super important that I record my fluid rates on the patient's chart, so we have documentation of what the fluid rates have been previously and what they are now. So the early signs of detecting intolerance is a patient's respiratory rate may start to increase and their effort may get a bit more increased as well. It can be quite subtle at first. You have to really look at your patients. You have to take the time to count their respiratory rate. And what you're looking for with these, it's not just a one-off, because if you go in and your patient's spooked or scared, yes, of course, it's going to have a respiratory rate increase. If it's just had an injection of pain relief, it's going to have a respiratory rate increase. It's all about trends. So over the day, has my patient's respiratory rate and effort increased, and is it consistent? I want to be telling my vet if that's what I've noticed. Increases in body weight as the days go on in the hospitalisation. Are they gaining weight every day? That's another early indicator. As I mentioned, excessive urination and even nasal discharge, okay, where we can see leaking of clear fluid from the nose. The late signs of fluid overload or intolerance are the pulmonary edema, so the crackles, the peripheral edema, so if they're getting nice big old puffy limbs, chemosis, such as puffy eyes, it's where the conjuncture of the eye becomes puffy with excess fluid. And if we start to see dyspnea, that's difficulty breathing, problems with breathing, then we are well into the late stages here. And the problem is if you're seeing the late stages, then you simply haven't been monitoring properly because you've completely missed the early signs. And it's really important that we recognize that so we can do better next time. So essentially, I hope you've enjoyed this different way of looking at fluid overload and the fact that it is not always a blameful or caused problem. It can be benign, that the patient was never going to cope with the fluids that we were given, but we weren't to know that at the time. So hopefully this just emphasizes the importance of monitoring patients on fluid therapy. It is extremely important that it is done, and we should be communicating with our vets. Ideally, our vets will be charting for monitoring as well, but if they haven't, it should be ingrained in us to do it, what to do, how often to do it, as I've just gone through there. 2 to 4 hourly respiratory rates and effort checks, listening to the lungs every time you're taking a heart rate, doing at least once a day body weight, if not more, for smaller patients and sicker patients, flagging excess urination to the vets, and recording fluid rates. And again, that can be an indicator. If you see that fluid rates have actually gone up, it can be a prompt that makes you think, hang on, I'll just look back. What was the last weight of the patient and how much urine have we been producing? And these should all be included on handover as well, ideally with the patients. This is how we are going to detect patients that are not tolerating the fluid, okay? Because that can happen just as easily as accidentally overloading a patient as well. So I hope you've enjoyed this. I hope it has been useful. Please let me know your comments.